Desperate times call for desperate measures. This is especially true for many of us in healthcare, as we find ourselves adapting to new roles and new units, innovating to tackle a new disease while adjusting to a new surreal reality. Hence, in an effort to re-establish some degree of normalcy, we decided to resume the release of our episodes on the Neurological Care Society podcast. Hey podcast listeners, Fawaz Al-Mufti here from West Cecil Medical Center, New York Medical College, and this is the Neurological Care Society podcast. Small, diffusion-weighted imaging, DWI hyperintensities in patients with acute intracerebral hemorrhages have been reported to be associated with increased risk of recurrent ischemic and hemorrhagic stroke, cognitive impairment, and death. Furthermore, they've also been known to evolve into chronic lesions and cause local microstructural injury. However, despite the multiple small series, the data on the overall burden of these DWI lesions in patients with ICH remains lacking. Today, Mike Brogan will be interviewing Rajeev Garg on behalf of his co-authors of their paper entitled Influence of Diffusion-Weighted Imaging Lesions on Outcomes in Patients with Acute Spontaneous Intracerebral Hemorrhage that was published in the Neurocritical Care Journal last October 2020. I hope you enjoyed this episode.
Hi everyone, welcome to the NCS podcast. I'm Dr. Benjamin Miller from the University of Minnesota, and on this episode we are speaking with Dr. Rajeev Garg from Rush University Medical Center about his paper, The Influence of Diffusion-Weighted Imaging Lesions on Outcomes in Patients with Acute Spontaneous Intracerebral Hemorrhage. Thanks, Dr. Garg, for joining us today.
Thank you for the opportunity.
So jumping right into this paper, it's a very interesting association that we're finding here. What caused you to start looking at this?
So we began this study back in about 2011, and it was largely based at that time on several small retrospective cohorts, including one that we had done when I was a fellow, finding these DWI lesions, or essentially silent brain infarcts in patients with spontaneous intracerebral hemorrhage. And the question we had at the time, since a lot of the data was retrospective, was, number one, what are the implications of these brain infarcts on outcomes? And then number two, is excessive blood pressure reduction causing these lesions? And the concept was that if these lesions were actually influencing outcomes, could they be a target for intervention in a disease at that time with really no proven therapy? And then regarding blood pressure reduction, our thought was that if blood pressure reduction is a cause for these lesions, could we approach blood pressure reduction in patients with ICH more cautiously? And this is before the Interact and Attack trial data really came out. So it really brought up the question of individualizing blood pressure management for patients with ICH.
So this, looking in MRI data, really kind of spouted from looking for interventional models. Coming from there, what was the most surprising thing you found out about this study?
I think what we found was two main things. Number one, that DWI lesions were actually associated with worse outcomes at 3 months. And we defined worse outcomes as a modified Rankin greater than 3. I think the second main finding that we had was that blood pressure reduction or blood pressure variability and change was not different between patients who had DWI lesions versus those that did not. So it really took us away from the leading hypothesis that has been sort of in the literature suggesting that blood pressure reduction is a main cause for these DWI lesions.
So for those of you who are following along with the paper here, I think he is describing figure 2, where the two populations are kind of matched together on kind of an interesting bar graph with the lines and variabilities for hour by hour, actually. So this looks like a lot of work to undergo. I was also looking at some parts of the paper talking about, well, actually, we'll go up to table 1, actually. And always, it was nice of you to bold the p-values on all of them, make it quick. But the pre-admission statin use, that's the one that, it wasn't like not insignificantly different in terms of raw numbers. Lesions absent in the statin use was quite significant. So do you think this comes down to just maybe small vessel disease being more prevalent in the DWI group, or do you think there's some causality here?
No, that's a great point, and something that we were actually quite surprised in finding. So when we looked at all of the variables that were actually associated with these lesions, the theme that was associated with all of them was the idea of possibly systemic or even local inflammation related either to the patient's underlying systemic response to the ICH or, for whatever reason, systemic inflammation. And there's been a lot of literature in the cardiovascular world and even in the stroke world that systemic inflammation may be associated with small vessel disease and large vessel disease, for that matter of fact. So the findings of statins being protective against these DWI lesions was really supportive of this concept that maybe inflammation is underlying the pathophysiology of these lesions. Now, there's a lot of work that needs to be done to prove that hypothesis, but it seems to make sense given all the literature that's coming out now about inflammation, coagulopathy, and microvascular disease.
Mm-hmm. That was a fascinating finding, I thought, anyway, but shows that statins are good for you and maybe need to be in the water, right?
Correct.
Another one that was sticking out to me, I mean, there's other significant findings, but one really stuck out to me, and there was actually two, and the comparison between the two is admission blood glucose was higher in the DWI lesion present, but looking at your A1C comparisons was insignificant. So I wonder what kind of association is there why you would present with a higher blood glucose on the initial population that have the DWI lesions. I don't know if you had any thoughts or there was thoughts in the background behind that.
Also, great point. So there's been a lot of literature that has shown that admission hyperglycemia has been associated with worse outcomes in patients with intracerebral hemorrhage and even ischemic strokes. And people have hypothesized whether this is a stress-induced hypoglycemia or is it possibly related to patients having undiagnosed diabetes mellitus. So it was interesting to find the association of admission hyperglycemia being linked to DWI lesions. And we don't have a really good explanation for this right now. But what it does bring up is a point of whether DWI lesions, admission hyperglycemia, and the independent associations we've found with worse outcomes are somehow interrelated with one another. And I think that really opens up the window to future studies to see, could we explain why admission hyperglycemia via DWI lesions could be related to worse outcomes in general?
That was a fascinating finding that really kind of confirmed some beliefs in my head about what I've been seeing and just never really could codify. You screened a lot of people in this study. I mean, it ran for a lot of years. I mean, you had 705 total people that you were able to, that were admitted with ICH, and you screened 660, so that's a crazy amount of work, I know, on your side. But at the end, what was some barriers to low consenting between, I mean, I know only 231 met criteria, but 100 people didn't consent. Was it unavailability of people, or was there some difficulties in the consenting process?
There was a combination of factors for patients that did not consent. I think in the majority of cases, these patients did not want to undergo an MRI scan, which we actually found really, really interesting because the MRI was covered by the study, and we told patients that, this is a way to assess for the potential of having a new ischemic stroke. And to our surprise, most patients just did not want to undergo an MRI for various reasons.
Was it predominantly the old claustrophobia excuse, or was there something that kind of surprised you in those people?
No, this is actually, outside of patients who are claustrophobic. So anybody who described severe claustrophobia, we actually did not even proceed with the consent process since we know that was going to be an issue. But these are purely patients that, for whatever reason, did not want to undergo an MRI scan.
So moving forward with all this, where do you think you're going to start focusing your efforts with respect to future direction?
I think for us the big thing is we're looking at a couple of mechanisms as being associated with this. So you brought up the issue of admission hyperglycemia, and I think where we want to take this moving forward is to prospectively look at patients that are admitted to the intensive care unit who may have these lesions and see what happens, what is their admission blood glucose, and more importantly, what happens longitudinally over the course of their hospitalization to blood glucose. There's a lot of data coming out based largely on cerebral microdialysis suggesting that, variations in blood glucose may be associated with secondary ischemic injury. So it raises a question of whether, with the use of glycemic control in the ICU, are we somehow causing these lesions to occur? That's one possibility. Again, something that's, one of many possibilities related to these lesions. We're also examining the idea of, as I mentioned, systemic inflammation. So we're taking the study in another direction where we're looking at various inflammatory markers in these patients with and without DWI lesions and trying to compare, do patients with these lesions have, for whatever reason, higher systemic inflammation that may be associated with these lesions compared to those that do not.
Yeah, that was going to be my next question in terms of the pro-inflammatory states that you were kind of describing there. I'm kind of seeing this segue into maybe an interventional trial with respect to inflammatory modulation. It was kind of suggested, I think, for those that believe that in terms of statins modulating neuroinflammation and such, that there may be a protective nature. I mean, this is just rough estimate, but can you see an interventional trial spinning off of this?
Yeah, I think the big one would be the use of statin therapy in ICH. There's been a lot of back and forth about the safety and utility of statins in intracerebral hemorrhage, and right now the current guidelines really don't describe which patients should be started on statins with intracerebral hemorrhage. Some of the more recent data that has come out has sort of suggested that statin therapy does not lead to an increased risk of intracerebral hemorrhage in patients that have ischemic strokes or have low LDL levels. So I think that statin therapy is something that needs to be examined in intracerebral hemorrhage patients. Now, I think one of the main points I want to make is that the presence of these lesions we don't believe is the cause for the decline, but we really think that the presence of these lesions is a biomarker for either recurrent cerebral infarcts, which some radiopathologic data sets actually found, as well as some imaging studies that have been published earlier found that patients with DWI lesions were more at risk for developing new lesions. So if that is the case, it's possible that starting these patients with statin therapy may actually reduce recurrent infarcts over the course of several months, and we may be able to change the trajectory of these patients from having poor recovery to improved recovery potentially. So I think that's one therapy. People have also talked about, even amongst our group, whether antiplatelet therapy would be beneficial for these patients. If we're assuming that these are local thrombotic events, is there a safe point at which these patients should be and can be started on antiplatelet therapy? Again, these are patients that have all sorts of underlying vascular risk factors, diabetes, hypertension. Some of them have very high hypercholesterolemia. So these are patients that if they were to present with an ischemic stroke, they would be started on antiplatelet therapy. What do you do in a situation where you have a hemorrhage and an ischemic stroke? Is there a time where we can say antiplatelet therapy is safe and actually beneficial for them?
Interesting. The use of statin in ICH reminds me of the StrokeNet trial. Currently, it's being ramped up, but with everything going on now, I know everything's kind of put on hold, but I think the Saturn trial, which is going to start taking off hopefully soon, might, hopefully, we'll see, answer kind of some of those questions. But the other part, I think another thing that I think you tried to really explain here was that the DWI lesions these were not like hemorrhagic transformations of small ischemic infarct. I think that you went to pretty good length here to make sure that these were not just ischemic strokes that then bled, I think. And in terms of locations of the DWI lesions themselves, was there a difference in the location of DWI lesions in terms of outcome, or was it just all comers?
Unfortunately, our study wasn't powered enough to look at the various type of locations of these lesions, and how they were associated with outcomes. We sort of found them in all various locations. And what we could analyze, what we did find was that a lot of the solitary lesions tended to be ipsilateral to the hematoma. But in patients with multiple lesions, which we define as greater than 2 lesions, they were sort of spread all over both supra- and infratentorially. And there did not seem to be a pattern on where they specifically occurred.
And I think one of the big questions that comes out of this is, has this really changed your practice in terms of counseling families and patients moving forward, or has it changed your diagnostic or treatment practices?
I think in patients that we do get MRI scans on in ICH, for me and I think for a lot of other investigators who are doing work in this area, it has changed practice because I believe there's a good amount of evidence at this point between studies such as ours, larger Eric's trial that showed similar findings, and some other cohorts that the presence of these lesions do in fact lead to worse outcomes at 3 months and in fact at 6 months. So the question comes is how many patients do get MRI imaging in ICH? Well, that becomes another independent question. Can we justify getting MRI scans in all patients with intracerebral hemorrhage when they're presented to the hospital? I think it's difficult to say that at this point since we don't have an intervention for these DWI lesions at this juncture. So the long and short of it is that, if a patient has an MRI and we find a lesion, I think it does for me counsel them on how they're going to do long term and what kind of strategies they can employ to help reduce potentially having a worsening functional decline. In patients that don't have MRI scans, really the question comes is that should we, as more data is collected in this area, be getting MRI scans on all patients with ICH to better understand what's going on in their brain and to better make adjustments to their risk factors in order to prevent these lesions from occurring.
Yeah, that's one I was struggling with, too, in terms of when do you get the MRI. I know sometimes you practice by getting the MRI 3 months down the road or so to see if there was an underlying lesion or some kind of vascular malformation that was being masked by the hemorrhage. But I was struggling with whether or not I changed practice at the outset and, all comers, did they get the MRI? And then maybe there's a subpopulation that you get it on, like those that presented with hyperglycemia at outset, since they seem to be the group that had the white matter lesions more, So, Dr. Garg, another part that caught my eye was your shift analysis down here in Figure 4 and the statistics shown in Figure 3, and then the statistics shown in Table 4. The shift analysis showed the line that you're looking at to be an MRS of 3 rather than prototypical MRS of 2. Is there any reason why we chose 3 over 2?
So when we collected our initial pilot data back in 2009, so about a year and a half, 2 years before the study actually started enrolling patients, our data at that time showed a difference in outcomes with an MRS of 3. So when we were putting the proposal together, we were trying to figure out how many patients we needed to actually have an adequate sample size and to have the study powered adequately. So we used MRS of 3 as our cutoff, and this was an a priori, hypothesis we had. So we did not do a statistical analysis to find which MRS would give us a significant result. As time has gone on, there's more and more supporting literature that probably MRS 2 is a more appropriate cutoff for patients with regard to functional outcome. So to help to better examine that, we actually did the shift analysis, and we found that for every level of MRS, there was actually a difference between patients who had DWI lesions versus those that did not. In other words, if you had a DWI lesion, you were still likely to have a worse outcome at 3 months compared to if you did not have a DWI lesion. So I think our studies sort of answered 2 questions. We did use a cutoff that's a little bit more generous, but at the same time, it does still show that the presence of these lesions leads to worse outcomes.
Thanks. That was kind of an important point to make from my mind. I'd just like to thank Dr. Garg for joining us on the NCS podcast today as we talked about his paper, The Influence of Diffusion-Weighted Imaging Lesions on Outcomes in Patients with Acute Spontaneous Intracerebral Hemorrhage. Again, thanks, Dr. Garg.
Really appreciate the opportunity. Thank you so much again.
Now in its 4th version, the Emergency Neurological Life Support Certification course focuses on improving care during the critical first hours of patients with acute neurological emergencies. ENLS demonstrates a collaborative, multidisciplinary approach and provides a consistent set of protocols, practical checklists, decision points, and suggested communication to use during patient management. The ENLS course is designed and accessible for all practices, from physicians to residents and everyone in between. The course can be taken exclusively online, or you can attend a live instructor-led course in your area or at a conference before completing the online certification. To learn more about ENLS certification, please visit www.enls.neurocriticalcare.org and use promo code PODCAST for an extra 10% off your purchase.
The
The NCS podcast series is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, and advocacy in neurocritical care. Our production staff includes Fawaz Al-Mufti, Ramani Baloo, Mike Brogan, Josh Levine, Benjamin Miller, Sterain Shepard, Jim Siegler, Sarah Sternnezer, and Chris Zamet. Our senior producer is Bonnie Rousseau. Our administrative staff includes Bonnie Rousseau and Angel Gindel. Music is created by Mohan Kadapali from the Division of Neurocritical Care at the University of Miami. The NCS podcast series is available on NCS On Demand and wherever you may listen to your podcast. For more information, please follow us on Twitter @Neurocritical or on Facebook. I'm Fawaz Al-Mufti, and thanks for listening.